Dr. Theresa Brooks. I am a board certified physician in the area of physical medicine and rehabilitation. I do have a private practice located in Grosse Pointe, Michigan, which is in the greater Detroit area. So thank you so much for joining me today. So today I'm going to cover a couple of things. I'm going to go through my educational background, explain to all of you why I chose the field of physical medicine and rehabilitation, explain what is physical medicine and rehabilitation, and some of the challenges, and also lessons I have learned, and then at the end take questions. And I think this is on maybe an auto thing because I'm not moving it forward, but it's moving forward. So once again, my name is, why is it doing this? Once again, my name is Dr. Theresa Brooks. Let me see. And I am a native of Michigan. I completed my undergraduate degree at the University of Michigan, went to medical school at Michigan State. I did an internship at Hurley Hospital that's located in Flint, Michigan. And I did my residency at Mayo Clinic in Rochester, Minnesota. And I am a board certified physical medicine and rehabilitation specialist. So once again, I am a Michigander. I was born in, well, actually not born here, but raised here. And these are some pictures. I included a lot of pictures in my presentation. I try to keep everyone you know, interested. But these are some of my high school friends that I am actually friends with most of these people still to this day. I completed my undergraduate degree at the University of Michigan. I actually was accepted to the College of Engineering, but realized early on that I wanted to be pre-med. So I switched to the College of LS&A, and I double majored in sociology and biology, and obviously graduated in 4 years. So during my college years, I had a lot of fun, but I was also very, very intentional about the activities that I participated in. I was very much about building a resume and in creating like a portfolio for myself. So even starting out, I started doing research. Even my very first semester, I did research in a dermatology department at the University of Michigan. And I did research over the summers at Wayne State University. I have presented research projects at various, you know, exhibits. And I also did international research where I was accepted. I received a grant through NIH to go to Guatemala and do research internationally. So that was a wonderful, wonderful experience. I did study abroad when I was in college. I went to the Dominican Republic. And these are pictures of some of my experiences. I did alternative spring break, which is where I spent my spring break volunteering. I did this twice. I volunteered in Newark, New Jersey, and also in Detroit, doing various things. And that was actually a wonderful, wonderful experience as well. And I was a resident in RA in college as well. So I was very intentional about building a resume and creating a portfolio that would look good, I thought, for medical school, in addition to getting good grades. So I was accepted to medical school, but I decided to actually defer my admissions for a year. Since I had double majored and I was, you know, had worked pretty hard, you know, academically, I decided I wanted to take a year off. And I had gotten accepted, and so I decided, you know, this would be a great opportunity to travel. So I actually participated in Semester at Sea, where I traveled around the world. These are a couple of pictures from my experience. I traveled to India, South Africa, Japan, China, Malaysia, Brazil. And it was an incredible experience. I spent some time in Los Angeles as well during this year, and just really tried to kind of rejuvenate my spirit, so to speak, and kind of gear up for the rigors of medical school. So I went to Michigan State Medical School. This is actually a copy of my white coat ceremony flyer, which is kind of your first introduction to medical school, where you take an oath to do no harm. Michigan State is a wonderful, wonderful program. They have both an MD program as well as a DO program. I was part of the MD program, but both programs are very, very well respected, throughout the nation, actually. So during medical school, you will make a lot of sacrifices. I sacrificed a lot of my time. It was very stressful. There's constant tests and evaluations, and it's not an easy time. But I still found time to manage to build up my, friends. These are some of my friends that I made during medical school, and have fun and try to enjoy myself, even though, it was challenging. This is just in the middle is a picture of, I don't know if anybody's a Michigan State basketball fan, but that's Coach Izzo. So that was kind of exciting when we saw him at a football game. During medical school, I also did some international experiences as well. I went to Ecuador one of my summers and learned about their healthcare system in another country, which was very eye-opening. It's always great to have a different perspective because there's such a variety of how people practice medicine and how it's implemented, and different countries and different areas just have such different levels of resources. We are very fortunate here in the United States with the amount of resources that we have, especially in the area of medicine and the technology that we have, but not everywhere has that level of resources and technology. So it's very eye-opening, and it's great to experience different cultures and to see how medicine is practiced in different places around the world. So during medical school, you rotate. So you spend your third and fourth years pretty much rotating through. That's the clinical portion of your medical school. So the first 2 years are more the academics, where you do your curriculum like biochemistry and physiology and all of those things. But then the second 2 years are your clinical years. The third year, you rotate through kind of your core curriculum. You do internal medicine, pediatrics, OB-GYN, surgery. So you rotate through kind of the core curriculums. And then in your fourth year, you have the chance to do electives, which are, maybe some areas that are not part of the primary care aspect, but you can kind of choose and do whatever you want to. So when I was so one thing you'll notice when you're in medical school is that there's definitely different cultures that are associated with different specialties. And so you may kind of attach onto one specialty or another, kind of just based off of your personality or based off the lifestyle or whatever reason that may draw you to a specific area. So I was drawn actually between family medicine and physical medicine and rehabilitation. I chose physical medicine and rehabilitation after I did my elective in physical medicine and rehabilitation for a lot of different reasons. I loved PM&R because of the team building that it entails. So you will often work in PM&R with a number of people like physical therapists, other specialists. You work with patients and their families to help get somebody better and to help to restore function. And so I love that. I love the building of the relationship building with patients. So you often spend extensive period of time with patients, and you're really hopefully helping them, get better. They may have experienced a loss in some way, and you're helping them regain function or optimize, their ability to live a full life. So those were things that I really, really loved about PM&R. I also felt like it was an area that really focused on a lot of lifestyle medicine and wasn't necessarily about just giving patients pain medications or other pills to kind of do a quick fix. It's really trying to look at a patient holistically and help them improve. So I really loved PM&R. And also, you know, there's a strong aspect of musculoskeletal medicine and sports medicine. And I was always, you know, pretty athletic and enjoyed sports and things like that. So it was also a draw for me in that regard. So what is physical medicine and rehabilitation? So oftentimes it was previously known as physiatry, but a lot of people mix that up with psychiatry. And so they kind of switched to physical medicine and rehabilitation, and we usually say PM&R for short. And so PM&R specializes in restoring and optimizing function in people with injuries to the muscles, bones, tissues, and the nervous system. And so there is actually a lot of overlap in PM&R with the areas of neurology, orthopedic surgery, and rheumatology. We obviously are not surgeons. We don't do surgery, but we will do other types of things such as injections. But it is a very holistic view of kind of somebody's musculoskeletal and neurological condition. So in the area of PM&R, there's a lot of common conditions that are treated. Probably the most common, especially when you're talking about general PM&R, is, you know, pain. There's, you know, low back pain is probably the biggest one, but then there's also neck pain, other joints such as knees, shoulders, hips. You can also focus on traumatic brain injuries, sports injuries, strokes, amputations, spinal cord injuries. Oftentimes you're dealing with chronic pain. You can deal also with fibromyalgia as well, is something I commonly see. So the residency training for physical medicine and rehabilitation, it's a 1-year internship. And then you do 3 years in the specialty of physical medicine and rehabilitation. During residency training, I did 6 months of EMG training. And you also will rotate through many different areas such as pain management, pediatrics, brain injury, spinal cord injury, cancer rehab, cardiac rehab, sports medicine. I rotated through a spine clinic, amputee clinic, wheelchair clinic. I did inpatient rehab and also even areas such as pulmonary rehabilitation. So rehabilitation really can encompass a wide variety of areas. There's even gynecological rehabilitation where people do like pelvic floor strengthening and things like that for women who are incontinent. So you really can go in a lot of different directions in the area of PM&R, which is a nice thing. One thing that PM&R doctors are trained in is EMG or electromyography. Only PM&R and neurologists are really trained in this area. So EMG or electromyography is a technique for evaluating and recording the electrical activity produced by skeletal muscles. So what we're really looking for are any sort of musculoskeletal or neurological conditions. And this is one of the best ways to test. There's really, you can't really do an x-ray and know that somebody has nerve damage, right? So EMG is the best test that we have to check for things such as neuropathies, myopathies, radiculopathies, plexopathies. And so that, you know, this is, you know, this actually involves a lot of extensive training, but it is an area that PM&R is very proficient in. Oh, and one other thing that I do as PM&R as well as injections. we're very proficient in injections, especially peripheral joint injections. I was trained to do both blind and ultrasound guidance. Some people do injections under fluoroscopy, but mostly for the peripheral joints, we can accomplish that with ultrasound, which is pretty safe for patients, and it allows for better accuracy of injections. So coming out of medical school, I first did an internship. So for certain specialties, including physical medicine and rehabilitation, radiology, there's some other areas that before you start your focus on those areas, they want you to do a year of either medicine, pediatrics, or what we call a transitional year, which involves internal medicine, pediatrics, and gynecology. You kind of rotate through everything again. But they want you to make sure that you're proficient in general medicine. And so because we're not doing primary care at all, we're very specialized. So they want to make sure that you have a good understanding, a good foundation of the basics of medicine before you kind of go on to your specialty. So I did what's known as a transitional year. I did that at Hurley Hospital, like I said before, that's located in Flint, Michigan, associated with Michigan State. And that was, I rotated between internal medicine, pediatrics, and gynecology for that year. So I did my residency at Mayo Clinic. And as I stated earlier, it was a 3-year program at Mayo Clinic where I rotated through all of those areas that I mentioned before. We were in the spine clinic. We did 6 months of EMGs. We did pediatrics. We did brain injury. I did a wheelchair clinic. I rounded on inpatients. We had outpatient, PM&R. I was actually in the hand clinic. And so one of the great things about Mayo Clinic is that obviously it's a top medical center. You see a lot of things there. I would say Mayo Clinic especially has strengths in orthopedics and neurology. And so PM&R really draws from both of these fields. And so the strength of both of these fields really helped my academic training a lot, or I should say my clinical training a lot, because we worked a lot in the orthopedics departments and also in the neurology department for a lot of my training. Sorry, something's popping up. Let me, I don't know. Can I reduce this or?
Yeah, that's on. You can reduce.
Okay, yeah, I see. Okay, and so Mayo Clinic was a wonderful experience as far as training. However, it was also challenging. I would absolutely say that my residency training at Mayo Clinic was the most challenging aspect of my academic career by far. And that was for numerous reasons. One was that I just overall didn't have as much of the social support that I had kind of in college and in medical school. It's a smaller town. Pretty much everybody either worked at Mayo Clinic, or I think it was AT&T or one of those technical areas. But most of the town really works at Mayo Clinic. So that was challenging. And the other thing that was really challenging was that academically, it was very rigorous. We had to stand up and, give lectures and grand rounds to people that were writing the books. And so it's very nerve-wracking to try to give a lecture to somebody who wrote all the articles that you're presenting. So it was definitely challenging, but I would definitely say coming out of residency, I had a lot of confidence in myself, my ability, my training. And so overall, I would say it was worth, kind of those difficult times. So after physical medicine and rehabilitation, there are fellowship opportunities. There's actually numerous opportunities. As I said, a lot of people don't realize how broad the area of PM&R is. It's a very broad specialty. So different fellowship opportunities include brain injury, hospice and palliative medicine. Oh, I didn't also mention we rotated through cancer rehabilitation as well. There is pain medicine, pediatrics, spinal cord injury, sports medicine, musculoskeletal and spine, stroke, multiple sclerosis, neurorehabilitation. Some people specialize just in EMGs or electrodiagnostic medicine. There's cancer rehabilitation, and some people go in the area of occupation and environmental medicine. I will be honest, once I completed my residency, I had no interest in fellowship. I was kind of ready to be done. And so I just kind of stayed in the area of general medicine, general PM&R, I should say. Once I did complete my PM&R residency, I did go on to receive my board certification. As I stated earlier, my training was very, very good, and I did quite well actually in my boards, which was good. But my board certification consisted of an oral board examination. I also had to complete a written board examination, and there are ongoing requirements for maintaining my certification. So every 5 to 10 years, I have to, pay dues to the Academy of Physical Medicine and Rehabilitation. I have to take continued CME credits, which are continued medical education credits. I have to do certain types of additional projects as well to maintain my certification and to show that I am, staying atop of the trends that are taking place in the area of physical medicine rehabilitation. Because I will be honest, being outside of academics, it's easy to kind of just fall into kind of your routine, but it's definitely important to continue your education. It really never stops. Reading articles and participating in different conferences and things like that. So it's important to kind of maintain that education, remain on the current edge of what's going on in your field. So life after residency was a little bit interesting. So I did actually a lot of things after residency as far as work goes. So initially, when I was graduating from residency, I was actually going to stay on at Mayo Clinic for another year because my husband at the time was finishing up his training. And so Mayo Clinic said, sure, we can keep you. Well, that happened to be during the economic downturn. It was around 2009. And all of a sudden, everything changed. And Mayo Clinic was like, they put a hiring freeze, and they were just worried that, they were just trying to retain the staff that they currently had. So they were like, we're really sorry, but we just can't do any new hires at this time. So I ended up working in a pain clinic that was located in the Twin Cities, about an hour and a half drive away. But they allowed me to work part-time, so I only worked 10 days a month, which was actually really nice. After residency, I also did moonlighting. So that's kind of also known as locum tenens, where you may work in a temporary position it could be a short period of time, it could be a matter of weeks, it could be a matter of months, it could be a matter of years. But the company will, fly you back and forth, they cover travel, they'll cover sometimes living expenses, and then they'll also pay you a wage for your time spent doing that moonlighting. So I did do that. Actually, that extended probably about a year and a half, and they covered my travel. So there was a period of time where I was actually traveling back and forth between Minnesota and Michigan to work at a spine clinic part-time in Michigan. So it was interesting. I've worked in an acute inpatient rehabilitation setting. After leaving Minnesota, I lived in Chicago for a few years and worked in Harvey, Illinois on an inpatient rehabilitation unit there. And I was there for about a year, year and a half before kind of moving back to Michigan and really starting my own private practice here. And I kind of moved back here for my children. I had children, and just to raise my kids and be closer to family, it was easier. I've also worked in skilled nursing facilities as well. And as I stated earlier, I currently doing private practice, and I also do some medical legal work as well, which includes like independent medical examinations or evaluating individuals that have been involved in auto accidents or workman's comp. I also will serve as an expert witness sometimes and give depositions and things like that. So I've really done a variety of things since leaving my training. So the essence of, general physical medicine and rehabilitation, when I see a patient, history is super important. Understanding, understanding, the pain that my patients may be having, understanding what kind of treatments they've received, understanding, all the quality, all the things that they tell you in medical school, the quality, what's your pain score? Where is it located? Does it radiate? Do you have any weakness? All of those kinds of things are really important in helping to come up with the diagnosis. So history is super important. You can never underestimate the importance of gathering a good history from your patients. Physical medicine and rehabilitation really focuses on a good musculoskeletal examination and a neurological examination. So we're really looking at the musculoskeletal and neurological system. That's what we are focused on. And we are trying to determine whether or not somebody's pain is due to these musculoskeletal or neurological conditions, or could it be due to something else unrelated to that. And so that's really our focus, and trying to understand the etiology of, typically they're presenting with pain, but understanding the etiology of that. Also, looking at diagnostic studies, ordering diagnostic studies is a very important tool in trying to help determine, coming up with the diagnosis and being able to properly manage or treat a patient. Sometimes, if you're lucky, you can see very clearly things on diagnostic studies that point to the reason why a patient may be having their problems. But oftentimes you'll kind of find some general issues that don't necessarily fully explain the cause or the source of their problems or deficits. And so, you kind of work with what you have and work in a stepwise pattern. Management of physical medicine and rehabilitation really involves, I believe, a lot of lifestyle, although that is hard to sometimes prescribe. But, just with even diet and exercise, so much can be remedied with just those things. But oftentimes, I will do I will refer patients to physical therapy. I will do additional diagnostic studies such as EMGs. I will do injections. Obviously, there's, prescription of pain medications, which I will get to in a little bit. And really trying to help, restore function or improve somebody's pain. So in the area of general physical medicine and rehabilitation, one of the biggest challenges that we are seeing right now is obviously with pain management. And so I will kind of give some stories. I have a lot of stories, but I will kind of give at least one story of an experience I had when I was working in a pain clinic. And so it can be very challenging, and you have to be very strict when you're dealing sometimes with administrating opiates to patients. When I worked in my first job just out of residency, I worked in a pain clinic, and I would often have patients come in and, request pain medications or request early refills on their pain medications. I heard every single story in the book about why patients sometimes need more opiates or, things like that. I had a patient come in once, and I don't know, I just didn't have a good feeling about her. She came in once and she requested, I think it was oxycodone or something. And I oftentimes don't like to give straight oxycodone because there's just such a high risk of abuse with that medication. And, I didn't feel comfortable. She didn't want to take any, she claimed to be allergic to anti-inflammatories and everything else. So I ended up, I think, giving her a prescription for something just really low level, low dose, So anyways, I never see her again. About a month or two later, I get a call. I get a call, or I think I got a letter actually, saying, why are you giving this patient so many narcotics? And they had 3 pages of all these scripts that were supposedly written by me, and where she went to like all these different pharmacies all over Minnesota filling these prescriptions. So anyways, what had happened was she had taken my DEA off of my prescription and was fraudulently using my DEA to basically call all these different pharmacies and pick up these prescriptions. So I had to file a police report, and they arrested her. I had to change my DEA, and that was just a whole big ordeal. But it was definitely an eye-opener as to how, just some of the extreme challenges that we have as providers managing some of these patients that are on these pain medications. And since then, well, I'll get to the next slide. So with pain management, there's been a significant paradigm shift. When I was in residency, the thought was treat patients' pain. Most patients are not going to abuse the medications. It's okay. It's just a very small percentage. The vast majority of people who you prescribe pain medications to are going to take it appropriately. We don't want people to suffer unnecessarily. It can affect their mental health. It can affect their quality of life. All of these things, very true. But I think it was very underestimated the significance of addiction and how often this happens. And so obviously in more recent years, it's been a pendulum shift, like the whole other direction, to the point where there are physicians being arrested and charged for prescribing opiate medications. And a lot of doctors are afraid now to prescribe these medications. And I've seen patients even coming out of surgery where, the surgeons will give them like 10 pills or something, because people just don't want to prescribe these medications as much anymore. There's a lot of concern and fear associated with it, which I understand. But it's definitely a challenging thing to find that happy medium, because, you know, the truth of the matter is that, you know, pain medications do work, and there's a reason why they are on the market. However, you know, it's really hard to really find the balance with everything, because, you know, it's just a challenge. I'll just say that. So they've definitely recognized, like I said before, that opiate use disorders have become a problem. Statistics are that even up to 1 in 4 patients receiving long-term opioid therapy in primary care struggle with opioid use disorder. And, you know, that's higher than what was kind of initially thought when I was in training. You know, they said it was maybe 10%, maybe even less than 10%, but obviously they're now finding that it's definitely more common. And so they've really monitored and cracked down a lot on prescription opioid use. And so this is kind of a graph showing how, you know, the deaths have really increased over recent years of people overdosing on these medications. And so it's definitely an issue, and there has been a lot of education and resources directed towards trying to improve this problem. Because, you know, for a while it was more street drugs that were causing the problem, and now more recently it has become prescription medications that have become more of a problem. But it's always trying to find, you know, that balance, because, you know, even if we reduce some of these prescription medications, I think that, you know, the street drugs kind of go on the rise again. So it's really a multifaceted challenge to manage these patients. So some of the things that I have adopted with managing pain patients, I will go through this pretty quickly. And I will be honest, as I stated earlier, there is a number of education and resources that have been directed towards pain management and dealing with the opiate crisis. And you know, I could really spend like a weekend probably talking about this. It could be a whole weekend course. I mean, because there's so much information out there now. But I'm just going to kind of focus on some of the things that I have adopted in my practice to try to safely manage patients and to try to be a responsible um, pain management kind of practice PM&R doctor. So when a patient comes into my practice, I will do, as part of my initial intake, I will do a depression screen on my patients. I do believe that screening for depression is extremely important. You know, I don't think you can separate the mental health from the physical health. Oftentimes patients who are in chronic pain have high depression level scores, and some of them are not receiving help. And I do believe that part of helping them physically is also helping them mentally as well. And if they do score high on the depression screen, will do a referral to a therapist for a focused mental health you know, program for them. I will also do an intake questionnaire. Like I said, history, understanding, you know, all of the information about someone's pain, how long it's been going on, what things have they tried, what do they do now, are they taking any medications, and understanding a history is incredibly important. I do my physical examination, like I said before, that incorporates a full musculoskeletal neurological examination is my focus. Now, when I am managing patients, you know, I first attempt non-opioid pain management. So the goal is to try not to get patients on these opioid medications and to try things like anti-inflammatories, muscle relaxants, things like that. And sorry. And so I will attempt that at first. Physical therapy is a big thing. I really like physical therapy a lot. I believe, like I said before, a lot in lifestyle management, exercise, you know, weight management. It's interesting how some patients actually don't correlate their health problems with their weight. Sometimes I have a patient whose BMI is in the morbidly obese category. She has chronic knee pain. And, you know, when I try to encourage weight loss, sometimes she doesn't seem to understand the correlation. For patients, if I do prescribe medications, controlled medications such as opioids, or even other controlled medications, I will check a MAPS. A MAPS is run by the state of Michigan, where you can actually see what pharmacies a patient has gone to and what they have been prescribed in the past. So it's really helpful for providers to see it, to make sure patients aren't doctor shopping, or you know, or they didn't just receive a prescription last week and they're coming in your office trying to get more. I make patients sign a drug contract. I do a SOAP-R, which is evidence-based questionnaire, kind of understanding the risk of abuse. It also helps me to determine how often I need to do a urine toxicology screen. So sometimes, you know, you only need to do a urine toxicology screen on patients, you know, twice a year. Sometimes you need to do it every other month. I will do urine toxicology monitoring. We have somebody who comes in the office and does the urine drug screens for our patients. Patients also have to sign a medication agreement, understanding the risk to these medications. And I also really try to wean my patients down to the lowest dose of pain medications possible, to still allow for quality of life, but to try to really reduce their dependence on scheduled medications. So just a couple quick things and I'll stop. So, you know, life lessons learned, be open to opportunities. My life has taken me in different directions that I never expected. I'm actually involved in politics now, which is kind of crazy. I was recently elected to city council in my city, and I'm currently serving as mayor pro tem. I have a husband, three beautiful daughters. I am also serving on the board to my physician organization. And so I have really become very actively engaged and involved in my community, and other aspects of my life have just become really, really full. And my final word is just stop and smell the roses. Really take time to enjoy the process. A lot of times we kind of think, oh, when I get to medical school, life is going to be great. Oh, when I get to residency, life is going to be great. Oh, when I get married, it's going to be great. Oh, when I have kids, you know, we're always looking to that next step for fulfillment and for, you know, thinking, oh, our life is going to be complete at that point. But really enjoy where you are, wherever you are at every point in time, because it really does go by quickly, and you will look back and say, wow, those were really some great times. You know, why was I so stressed? Why was I so anxious? You know, I should have enjoyed it more. So really, really take time to really enjoy life. And so that's it. I will open it up to questions, and thank you very much.
Thank you so much. This was so great. There's so many comments just in all of you. Also, pictures are beautiful.
Oh, thanks.
You're welcome. So we had a couple questions. Let's see. Some of them were asking, let me see if I can find it. Chat's blowing up. First, how, you know, you got involved in politics, and if that has anything to do with like medical advocacy or just something that you're enjoying on beyond just that.
So absolutely. At the city level, there's only so much I can do directly with medicine. But I definitely, especially with the COVID crisis, I definitely see how much there is a disparity in access and quality of care to minority patients. The majority of my patients are actually Black. I'm in, I practice in the Detroit metro area, and I definitely saw a lot of issues with COVID, and it has motivated me to really focus on trying to improve these health disparities. At the city level, there's so much we can do directly with healthcare, but indirectly, there's a lot of things we can do to try to improve people's quality of life, and with parks and recreations and things like that, access to educational opportunities and those kinds of things are there. So it's definitely an emphasis of mine. Yes.
Great, thank you. There were some other questions kind of earlier on talking about or asking if there's anything that is there anything that you would have changed about your journey, or looking back now, would you want to do anything, and if so, what would it be?
To be honest with you, there's nothing I would have changed about my journey. I think my journey was really full. As I stated earlier, you saw my international travel. I really tried to enjoy things. The only thing that I wish maybe is that I enjoyed it more. I spent a lot of time stressing and being anxious, like, oh my gosh, am I going to get into medical school? Oh my gosh, and so I guess it's hard not to be stressed and things like that. But looking back, it's like everything really turns out the way it's supposed to turn out. And so I that's why I said really try to enjoy, because life will pass you by, and you want to really live it to its fullest. And I know it's kind of cliche, but it's very true. And you don't want to spend your years just being stressed out and anxious and worried about everything. You need to really enjoy where you're at whatever point you're at in your life.
Yeah, definitely agree. There was also a question earlier, if you could explain, it kind of sounded like to some people that PMR could be a little bit like physical therapy. Could you explain, what the differences are really, and,
Sure.
compare and contrast?
Absolutely. So a lot of people do kind of conflate the two, physical therapy. So we work with physical therapists. Physical therapy is an important aspect of PM&R. But as PM&R, you are a doctor. So I can prescribe medications, I can do injections, I can perform diagnostic studies like the EMG, I can refer patients to other specialists. I am giving them a diagnosis. If in trying different treatment plans, if that plan changes, so physical therapy is kind of an option of treatment, but a physical therapist isn't evaluating a patient. They're not sending patients for x-rays or MRIs. They're not referring patients to other places. Their focus is on the exercise aspect of the treatment plan. And so they have a very important role, and I rely very heavily on physical therapists. But as a PM&R doctor, I am still a doctor. And so a doctor involves medical things, and especially depending on what area of medicine you go into. When I was working on inpatient, I was managing patients' diabetes, heart failure, all that kind of stuff, so you're still a doctor as a PM&R doctor, whereas a physical therapist has a different set of skills.
Great, thank you for explaining that. Appreciate it. There was a question earlier also asking, if I could find it. So do you treat any sort of autoimmune diseases with any like comorbidities with like the GI tract or anything like that?
Not as much. I mean, there are autoimmune disorders, I guess, like MS is autoimmune, so I've treated patients with, MS. GI, if they specifically have a GI disorder, no. I would send them to a GI specialist. but there's overlap of a lot of things, right? So a lot of patients with, say, for example, fibromyalgia, a lot of them have irritable bowel, or, there's overlap of different conditions, and so if they're seeing somebody specifically for abdominal issues or GI issues, no, they need to see a GI specialist. But my goal is to help them restore function. So like I said, if I see a patient with autoimmune disorders such as MS, trying to make sure that they have access to everything they need, adaptive equipment. Sometimes people need canes, wheelchairs. We write those prescriptions. Physical therapy, we do that. Is there swallowing off? Do they need to see, a speech therapist? Or perform a swallow evaluation, things like that. So we kind of really look at patients as a whole and say, what are your deficits? What are you unable to do? Are you weak on this side? How do we compensate and improve that? And you have to look at all the different tools in your toolbox and make sure they get the proper care that they need to get better.
Great. Thank you for sharing that. I think we'll finish with one last question. As we are in a very weird time with COVID, and the pandemic has taken away a lot of opportunities, which we're so thankful that you're here to help us. Is there any last piece of advice you'd like to give us as pre-med students and post-bac students trying to navigate through this very weird time?
It is hard. I talked to a pre-med student who's looking at residencies, and she unfortunately can't even go on interviews. And so she's just trying to call people to figure out what's it like, and it's really hard to gather that information from a video visit, But I would just say, like I said, the things that I felt were very helpful as a pre-med student were build your resume, create a portfolio for yourself, get involved in as many activities as you can. So that, get a broad range of experiences, and don't just, it's important to have the academics, but you want to be a well-rounded individual as well. Definitely, if there's areas of medicine that you are interested in, try your best. There's still doctor's offices that are open. Try your best to physically get in with somebody. If there's people locally that and you say, hey, can I come in for a day, or really sit down with you and understand, what it's like, or get have an experience. I think that's important. I think for medical school, they're really looking at kind of those things. Do you understand the field? Do you understand what you're getting into? Because a lot of people think they want pre-med, but sometimes people don't fully understand what medicine entails. So really having a good understanding and being able to show that to medical schools, that yes, and even especially if you can have a letter of recommendation or something like that from a doctor, I think is helpful. So I don't know. Those are things that I think are very helpful, to focus on. So hopefully I answered that question okay.
Yes, thank you so much. We absolutely appreciate it. Thank you so much for being here. If you want to